Hello, 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 Macedonia family and friends, Albion community. We are so happy that you are here tonight.
Hello, hello, welcome, 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 everyone. God bless you for joining us tonight. And we are hoping that you'll join us for the next tonight and tomorrow night for our 2022 Mental Health Symposium.
Woo!
It is an amazing lineup. It is some valuable information, and we are just super, super excited that this is what God has allowed to come together one more time, especially in this age of COVID and everything that has happened over the last couple of years. We know that this is important information. So if you're on already, go ahead and hit that share button. Make sure everybody knows that the Macedonia Church Ministries, in partnership with all of these great professionals, we're here with our 2022 Mental Health Symposium. Amen.
Yes,
Amen.
yes. And you'll hear this from several others as we go through the night, most notably Marquetta Frost, our program coordinator. This year, we want to take a more in-depth approach than we have in the past. When we first launched the first mental health symposium, we were very interested in making sure people came to the church and understood what resources were available to Albion and to the community. We wanted to make sure that the panel spoke out on various mental health issues, and that was helpful. People had a great response, and we were able to have a virtual session last year that went over topics that we hadn't explored the first year. So now, this year, in addition to letting you know more about mental health topics of concern in our churches, in the community, among our families, among our friends, we also want to talk about some conditions that lead to a lot of mental stress and how you can look at what the symptoms are in yourself, in loved ones you see, and avert or ward off some of these conditions before they have a chance to really manifest, and also how you can support people who are living with these conditions and with these treatment options, because even the best treatment options can sometimes have side effects that we have to live with that are definitely still better than the condition or the disease itself. But we want to make sure that we are sharing how to support others and how to ask for support for yourself. So tonight we want to do something really, really special in the mental health care realm. And we're just excited that you're here to join us.
Awesome. Awesome.
So now, a special treat. We have a few words from our pastor who really teaches a whole person methodology for wellness: spiritual, physical, mental, emotional. And with no further ado, I would like to turn it over to our pastor, Bobby Joe McKenzie.
Well, thank you. Thank you, First Lady McKenzie. Thank you to the Macedonia Ministry. Thank you to all of our partners who will be joining us and presenting tonight. Thank you to all of you, God's people. I was asked to just say a quick word, and it'll be a quick word on mental health and faith. And it was brought to my attention, to my surprise, it was brought to my attention that possibly some of my own colleagues take a slightly different approach when it comes down to mental health and faith. That if you are having a mental health crisis, or if you have a mental health diagnosis, that in a real sense, depending on what it is, all you need to do is pray. And though I support prayer 100%, prayer is always, as a matter of fact, the Bible says men ought always pray and faint not.
Yeah.
But we at the Macedonia Ministry, and we believe we're on good ground. We support, and as the First Lady, as my wife said, we support and promote a holistic approach to healthcare, period.
Yes.
What we believe is that mental health is health. It's just a part of health. We are body, we are spirit, and we are soul. And if your body is injured or if your body is sick, as a pastor, I'm going to recommend that you go see the professionals to help you get your body well. Well, if your soul, which actually is where your mind and your emotions are housed, if it is sick, I'm going to recommend you go and get help from professionals who can help you with that. It would be irresponsible of me and of us to tell you, well, your arm is broken. Don't go to the doctor, just pray. So we wouldn't take that approach with your physical.
No.
So we don't take that approach with your mental. What we believe is that if you have a even a slight reason to think that there you need help, please, sir, please, ma'am, go get help. If you have already gotten a diagnosis of whatever, make sure that you are staying tight to the program and the regimen that has been set up for you. Take your medicine if you've been prescribed medicine. Go to your appointments. Make sure you are open and honest with your clinician and with your doctors to make sure that you are getting the very best care. We believe that there's no conflict with faith and mental health. As a matter of fact, I just happened to read my Bible one day, and I saw a couple of scriptures that jumped out at me. The first thing that jumped out at me, I read in Ephesians chapter 6, and I believe it was around verse 11. It says, put on the whole armor of God. And so the whole armor is to protect your whole being. And then if you go down to, I believe, around verse number 17, it talks about putting on the helmet of salvation. And salvation is supposed to actually save the whole being. And so it should save your mind as well as your spirit and your body. And so we believe in a holistic approach. And then I know that there is no conflict with faith and mental health, because I saw one of the greatest characters in the Bible have a mental episode. First King chapter 19, I believe, you will find Elijah having ran from Jezebel. Yes. And he was hiding out in a cave. And at first he was hiding out underneath a bush, I believe, and he prayed to God to take his life. He then fell asleep and had to be awakened by an angel to tell him to actually get up and eat something. And then he immediately fell back to sleep. So I saw even a strong man of God who had a situation with his mental. And so there's no conflict. There's no conflict with faith. Amen. And mental health. As a matter of fact, you're exhibiting true faith when you actually access all of the blessings, all of the tools, all of the persons, if you will, that God has uniquely blessed and given them abilities to help. You actually exercise your full faith. Yes. When you actually access the full blessings of God. And so tonight, I just want to make sure that we are on the same page, that you're on good ground when you hear these clinicians and you hear these professionals say, hey, we understand, and here's what we recommend. Here's some information that'll help you. And so to all of the Macedonia membership, and then to all of the Albion community, and then to all of you, my brothers and my sisters who are viewing, no matter where you are, if you'll allow me to actually lead you and be your spiritual leader, at least for the next 2 nights, trust and believe I am absolutely with you and promoting that we have faith, but we also actually have professionals to come alongside and partner with us as it pertains to our mental health. And so that's all I have. I just want to encourage you to take in all the information, enjoy what is about to take place, but take it serious. These are amazing presenters and they've come to bless us. So without further ado, my brothers and sisters, allow us to be blessed with the 2022 Mental Health Symposium. God bless you.
God bless you. Hello again. I'm so excited and delighted that I get to introduce someone who is not just a member of the congregation, but who is a noted healthcare professional. I would like to, without further delay, introduce Sister Jaleesa Adkins. Her bio is on screen, as you can see, and she is an adult gerontology nurse practitioner. Jaleesa Atkins has been a member of Macedonia Missionary Baptist Church of Albion since 2015. She has worked in healthcare for many years, starting at the age of 17. She attended Baker College of Owasso and received an associate's degree in nursing and became a registered nurse, RN, in 2010. She has worked in several specialties, including medical surgery, long-term care, long-term acute care, hospice, psychiatry, and administration. Jaleesa went back to school and received a bachelor's degree in nursing from Spring Arbor University in 2016, then later went on to pursue a master's of nursing at Spring Arbor as well. She graduated in 2019 and became an adult gerontology nurse practitioner in 2020. Yes, during the pandemic. Jaleesa has worked as a psychiatric nurse since 2014, mainly working with adult and geriatric patients. Since becoming a nurse practitioner, she has continued to work with inpatient and outpatient psychiatry, seeing patients from the ages of 13 on up. Nursing is always what Jaleesa wanted to do, and her heart is to serve people. Today, Jaleesa will bless us with a presentation on depression and suicide prevention.
Good evening, everyone. Good evening. Good evening. I am so happy to be a part of this year's Mental Health Symposium. Today, I'll be giving out information regarding depression and suicide prevention, and also touching a little bit on substance abuse. As First Lady mentioned, I currently work as a nurse practitioner. I work in outpatient. I also work in inpatient, rounding at a freestanding hospital in New Baltimore, Michigan, and that is where I see adults and teenagers as well. So I will have you guys just follow along with my PowerPoint presentation. And if there's any questions, please feel free to go through on the private chat, and I will try to address them as we begin. So again, depression, suicide, and substance abuse I will be going over today. Depression, it can be described in so many different ways. This is a very simple, condensed, concise definition. Depression is a mood disorder that causes a persistent feeling of sadness and a loss of interest. Other names include major depressive disorder or clinical depression. It affects how you feel, think, and behave, and can lead to a variety of emotional and physical problems. Causes of depression. There are many causes and sometimes various factors that can combine to trigger symptoms. Factors that are likely to play a role in the causes of depression are genetic features, changes in brain neurotransmitter levels, environmental factors, psychological and social factors, and stress from life events. Things that are new in our life, such as becoming a new mother or going through a divorce, things like that. So while the medical community does not have a full grasp or a full explanation of the cause of depression, we realize it can be a variety of things, as mentioned in the PowerPoint. Any period of your life that causes any instability can definitely contribute to a depressed mood. So what does depression look like? Again, this is very subjective, but these are just kind of a condensed list of some signs and symptoms of what depression looks like. So a depressed mood, a reduced interest or pleasure in activities you once enjoyed, changes in appetite, either eating more or eating much less, intentional weight loss or gain, sleeping too much or too little, agitation, restlessness, pacing, up and down, slow movement, speech, fatigue, loss of energy, difficulty thinking, concentrating or making decisions, crying spells, not wanting to get out of bed, meltdowns, emotional distance, and becoming isolative, which is a huge deal. One of the ways as a provider, this is one of the ways that we can kind of measure what depression, the severity of your depression. This screening also shows us the progression of if the treatment is appropriate for you. So if you have already been diagnosed with depression and you're going to therapy or taking medications, this screening can also be done to kind of measure that as well. So I know that many of us go to the doctor as women. We get, we have mammograms, we get different testing done on a screening basis, and depression screening has become one of those things that get done in your primary care doctor's office because depression has become so prevalent. And because it's become so prevalent, the biggest thing for us is we want to catch it early. Having a diagnosis of depression doesn't necessarily mean that you have to take medications, but this tool is one of the things that guides us to let us know where you're at with your depression and how severe it is. So this has multiple purposes, like I said. So the scoring of this depression screening and Macedonia, we did this, I think, a couple years ago with our congregation, where we kind of gave everyone this screening tool to kind of get an idea. I think this might have been our first or second year doing our mental health symposium. But the scoring, so 0 to 4, minimal depression, 5 to 9 is mild, 10 to 14, moderate depression, 15 to 19, moderate to severe depression, and 20 to 27 is severe depression. So based on the scoring, treatment options may vary, and it just, again, gives your provider an idea of where to go as far as treatment. So treatment for depression. Depression is treatable, and managing symptoms usually involves one or all three of these components. Support, which is the biggest thing. This can range from just discussing practical solutions and possible causes to educating your family members. Psychotherapy, also known as talk therapy. Some options include one-on-one counseling and cognitive behavioral therapy, CBT. And of course, we have drug treatment. A doctor may prescribe you medications, and there's other lifestyle modifiable ways to help combat depression, including, healthy diet, incorporating exercise, getting enough sleep, and avoiding drugs and alcohol. One of the things that we wanted to touch on this year specifically was teenagers and depression. And I see teenagers twice a month when I go around at the freestanding psych hospital in New Baltimore, Michigan. And when I first started a couple years ago, I was kind of mind blown at how many teenagers suffer from depression and how many teenagers suffer from suicidal thoughts and even suicide attempts. So I think that it was really important for us to for me to do, a little education on what that looks like and what we can do to try to help our teens who may be struggling. So as you see on the slide, teenagers and their presentation of depression can be very different from adults. And they experience depression because of different reasons. So as a teen, you're going through puberty. You may not, as a female, you might not grow up, hit puberty until you're older. You might look smaller than other. With the guys, you might look smaller than other guys. So you might, get some teasing or bullying with that, peer pressure. And they might have some of the symptoms, withdrawing from family, difficulty with schoolwork. If you notice that you had a straight A student and now, they're going to high school and they're in the 9th grade and now all of their grades are failing. Feeling guilty, helpless, or worthless, restlessness, such as inability to sit still. So it's important to know that the signs of depression are different. And parents, there are a few ways you can offer support to your teenage child. I just want to pause. I do see a couple questions and I will get to them as soon as I get done with a couple slides. So ways to support your teen. Seek professional support. What that means is, like Pastor mentioned before, don't feel embarrassed. Don't feel like this is just going to be washed away. If your teen is displaying any of these signs and you guys have a conversation and think that this possibly could be depression, you want to intervene as early as possible, because that is really makes a successful treatment is when it's early diagnosed. Ask your pediatrician to screen for the depression. In the office, like I said, this is that PHQ-9 form is readily available in all doctor's offices, so it can be easily, checked. When I say offer tender support, remind your teen you love them, give them hugs, show them that you'll always be there, give them physical, affirmations and verbal affirmations to let them know that you love them, you care about them, and whatever they're going through, you're there to help them and support them. So when I say assist in refraining from teens' negativity, that means when they talk negative about themselves, which could be another sign of depression, you want to ask, why are you saying that about yourself? Trying to get to the root of the problem to see, why do you feel like that? Why do you feel like why are you saying those negative things about yourself? Set up an environment that encourages success. It could be as simple as just recognizing those small accomplishments that they have in school or in their personal life. And another big thing is never tell your teen to snap out of it. If this is truly clinical depression, this is not something that can just go away. Offer help to them, work side by side with them as they struggle with their mood changes, and then help them to get engaged and keep busy. It might be a sport, it might be something in church, and, just to get their mind focused on something else. So suicide and depression. Suicidal thoughts are thoughts about hurting yourself or taking your own life, and can occur when a person is in an intense emotional pain and doesn't see a way out. The things that cause this type of pain are different for everyone. Suicide is often preventable, and it can be linked to depression, suicidal thoughts, and this can happen to anyone, young and old, male, female. No one is exempt. So suicide and depression, some risk factors, age, gender, poor physical and mental health, which we will get into. As First Lady mentioned, our physical health definitely correlates with our mental health. And I'm so glad that this year we are kind of looking at the whole body and how that, can affect our mind. Family history of violence or of suicide, a history of violence, having weapons in your home, having recently been released from a long time stay in prison or jail, hanging out with others who talk about suicide or encourage you to take your own life, and traumatic events. Some warning signs to look for: feeling hopeless, feeling worthlessness as a provider. Those three words are really a risk factor for me when I have a patient and I'm screening for depression. When they say those words, I'm concerned, because at that point, you might be already having those thoughts of suicide because you feel like you're nothing. Feeling unbearable, having emotional pain, focusing on death, dying, or violence, feeling that friends and family will be better off without you, making a plan or searching for a way to take your life, feeling guilt or shame, using drugs or alcohol more frequently, extreme anger, rage, or revenge, giving away things that once mattered to you, saying goodbye to friends and family, or writing a note, making a will, or putting your affairs in order. If you see any of these signs in any persons, whether it be male, female, young, older, teenagers, these are all major warning signs that we want to keep out for. If you are feeling suicidal, if you encounter someone who you feel are at risk for suicidal thoughts, this is what we can do. And the main reason when I talk to people and I ask them, what made you want to take your own life, or what is going on with you that is making you have these thoughts of suicide, and a lot of times they just feel like they're in so much pain and it's never going to end. They're always going to be in that spot. They don't see the light at the end of that tunnel, and that's why it's time to reach out for some help. And suicidal thoughts, like I mentioned a couple slides ago, are often suicide is treatable, and the thoughts come due to untreated diagnoses such as depression. You go years and years and years without getting help, and the depression continues to get worse. And that's when those suicidal thoughts start to creep in, because you just feel like this is just a vicious cycle. I'm never going to stop feeling like this. So reach out for help. No, you are not alone. There are several mental health professionals, providers, even your primary care doctors that can point you in the right direction. And I know either today or even tomorrow, there will be people talking about what to do in crisis if you're feeling like this, and the different avenues that we have in our own community when feeling this way. And then it's important to tell somebody that you are having these thoughts. What's going on? Call your family, call your friend, call a church member. Just reach out in whichever way that you feel comfortable. Avoid things that trigger the suicidal thoughts. Again, I'm going to touch on this in a couple more slides ahead, but alcohol, drugs. A lot of people tend to use alcohol and drugs when they have a mental health disorder in order to kind of cope with those feelings, because they never gotten professional help. So what those things do is they make it worse. So we want to make sure that we're staying away from those things that cause it to increase. Taking care of your health and wellness, as I mentioned before, exercising, eating right, having a healthy diet, and then of course working with a professional when you reach out because of your depression symptoms. That person then, and then as an outpatient provider, you have an established person who knows your case, knows your medications, knows you as a person, kind of builds a rapport with you, so that if you continue seeing that, I have patients who I see on a monthly or bi-monthly basis, or every 3 months, to do a check-in and say, okay, how's your medications working? You going to therapy? Anything we need to look at? Anything we need to change? Things like that. So it's important to kind of keep track with those and be compliant with those appointments as well. So these are just a couple of illustrations of how substance abuse and depression kind of interlink together. 33% of individuals with major depressive disorder engage in substance abuse. And on my right, it shows just kind of the cycle of the addiction and how it just is never, it doesn't stop. So substance abuse is, I see that all the time. especially in inpatient. A lot of times when people come into inpatient, it is a emergent situation. We feel that they are harm to themselves or others, or they are totally they're in a psychosis, and a lot of times that can be brought on because of substances that they've used to try to deal with their mental health disorder and not following appropriate medication, following their medication prescriptions and taking their medications as they need to. So substance abuse and depression often work in cycles together. So know that one may contribute directly to the other one, as I just mentioned. It is a vicious cycle. Those suffering from depression have an increased likelihood of substance abuse, with those who do abuse drugs are at risk for increased risk for depression. So it's interlocked together. They kind of go hand in hand when dealing with mental health. And be aware of self-medicating. The majority of people who with depressive disorders abuse substances to self-medicate. They want to try to get rid of those negative feelings. And while they might find a temporary boost in their mood, and I say temporary, those negative symptoms or feelings might go away for a little bit, and they might have a boost in their mood very temporarily. Long-term effects is much, much worse. Substance abuse is not the way to deal with your depressive symptoms, and it can lead to very, very serious consequences. Before I hit my last slide, I just want to read the couple questions I have here in my chat. So one of the questions was, is there an easy way to find the right therapist for a teen? The problem is that teens and adolescents is very limited. The pediatricians, even in Jackson County, there's pediatric psychiatrists, is limited. I could definitely look into this to see, as far as our community, Alabama and Jackson community, to see what type of resources we have in order to find therapists. I know that I used to work at Henry Ford Allegiance Health on the inpatient side, and a lot of times when we don't have a pediatric unit there, but so teens would have to go, 2 hours away, 3 hours away to different places to get treatment, because we just don't have enough pediatric psychiatrists available. Let's see. Is there an easy path to finding the right therapist? Okay, I got that. And then, when a person is feeling intense emotional pain and craving relief, is that the time that you should reach out to a person for help? Absolutely. I'm hoping that you have reached out to someone prior to that feeling. A lot of times depression is very gradual. It's not intense right away. A lot of times we kind of bury those feelings, and like I'm going to mention on my last slide, I'm going to be okay. And then, something else happens, and it's just kind of like the straw that broke the camel's back, that can be just detrimenting to you. And then it causes you to be in that emotion, that severe emotional pain. So yes, you definitely want to reach out for help when you're feeling that way. Traumatic events definitely trigger depression and mental health issues. A lot of times that can be the very cause of why you're feeling depressed. I can just say, for me, one of my testimonies, my mother was in the hospital. She had a surgery, and literally everything that could happen to her happened to her in a negative way. She is doing so good now, thank God. He has definitely blessed her and spared her. But my mom had to move in with me at that time. And while I am so used to taking care of everybody else as a nurse, that was hard for me. It's an adjustment. So when you have traumatic events, and I wouldn't say that was a traumatic, that was just a kind of an instability for me. And I didn't really get depressed, but those are type of things you just kind of have to check yourself and say, hey, this is not normal for you. And okay, what are we going to do? What steps are we going to take to try to help to make this a stable transition? Traumatic events, someone passing away, having an accident. I have a lot of patients who deal with post-traumatic stress disorder. females who have had been rape victims or have had, been molested as children. There's different triggers that kind of bring back those feelings. So traumatic events definitely trigger depression and mental health issues. Why do some doctors prescribe marijuana for depression? So marijuana is actually not, in the state of Michigan, marijuana is a recreational drug at this point. So as far as having physicians who prescribe marijuana is very, is not very prevalent anymore because it's not required that they have a card or anything like that. So, but they prescribe marijuana for several reasons: anxiety, to help them sleep. And as a medical professional who does prescribe medications, there's medications I can prescribe for anxiety. There's medications I can prescribe for sleep. But there are patients, some of my patients, who actually use marijuana for those things, and they are helpful in that, for those symptoms. Can mental health improve without medication over time? Absolutely. When I see patients, especially on an outpatient basis, initial, I call it a psych evaluation. When I initially see them, I do not hone in on taking medications. I kind of evaluate the patient to see where they are. And unless they're like going through like a severe psychosis, I don't push medications on everybody because it's not needed. But when it is prescribed to you, it's important to be compliant with them. But no, you do not have, it's not absolutely necessary to have to take medications in order to improve your mood. Sometimes just having that therapy session once a month or every 2 weeks can improve your mood significantly. Or, changing your regimen as far as your, different hobbies or different people that you're around can definitely elevate your mood as well. So I just want to go over my last slide, just to kind of wrap everything up. And the reason why I picked that picture, and it says I am fine. And I don't know how many times I know I've said it and I have not been fine. But we as people, how are you doing today? Oh, I'm fine, I'm good. And everything could be going wrong. And you could be having all of these symptoms, having all of these problems, and that is kind of that coin term is I am fine. And it is okay to not be okay. It is okay to say, no, I'm not fine. I'm messed up and I need some help. And it's okay. There's nothing to be ashamed of. Life happens to everyone. We all deal with life very differently. And any of these things that I've mentioned in my presentation, if you're having those symptoms, you definitely want to make sure that you are reaching out for professional help. And don't be afraid to ask for help. Like I said, you might be, if you need to call a friend, a family member, your primary care doctor. If you don't have any established mental health diagnoses and you're not sure if you have them or not, your primary care doctor can definitely refer you to a psychiatrist. Or as far as, for me, I'm not a psychiatrist, but I'm a nurse practitioner who works specifically in psychiatry. But they can just direct you in the right direction as far as you're dealing with your symptoms. So I just wanted to end on that note to say it's okay to not be okay. It's okay to say, nope, I'm not okay. I need help. And I'm hoping that all of this information was helpful to everyone. And I will definitely look into that question about teenagers and therapists in our community for sure. Thank you.
Thank you so much, Sister Jaleesa. That was so wonderful, that all the information that she shared tonight. I learned a lot from her, and I appreciate the gifts that God has provided the church body to help itself. And thank you, Pastor Mackenzie and First Lady, for all the leadership and what you provide for us to be able to share with the community. And thank you for speaking on faith and mental health. Our next presenter is here, and we are excited to present to you Mr. Arturo Puckerin. Arturo Puckerin is the president and CEO of Neighborhoods Incorporated. This self-described Army brat was born in Brooklyn, New York, and spent his formative years in Long Beach, California. And Michigander for nearly a decade, Puckerin is now looking to establish a connection to Calhoun County, where he is tasked with leading the housing nonprofit Neighborhoods, Inc. of Battle Creek, and its new president and CEO amid the challenges of the COVID-19 pandemic. Priority one is really triage, and we're kind of there, said Puckerin, never being able to turn away anyone. That's what expanding the scope of our services is all about. Neighborhoods, Inc. of Battle Creek provides services and educational programs for people of low to moderate incomes, promoting healthy, stable homes and neighborhoods. Tax records from the financial year that ended in June 2020 shows the nonprofit had nearly $13 million in net assets, including over 50 rental properties, with $841,120 in total program service expenses. The organization launched in 1981 and was recently bolstered by doubling its staff to 22 after becoming the new home to the Calhoun County Housing Services, formerly operated by Summit Point. Mr. Puckerin will be talking about homelessness and unhoused and the services that they provide to the Albion community as well as Calhoun County. We welcome you, Dr. Puckerin.
Hey, everybody. I hope everybody had a great Easter. Hope everybody's enjoying the April snow showers here. Just wanted to thank God for being here. It's been an interesting 2 years now. One of our first Easters really kind of being together. And, speaking of such, we're navigating, we're solving so many of these issues and challenges that we have in our community and in our nation. And I'm just excited to be here, making Calhoun County my home and working with all of you. I wanted to touch on housing and its relation to mental health and the work that we'll be doing pursuant to such. And if we could begin with slide 1. There we go. So homelessness, I wanted to start first and foremost with homelessness defined. There's essentially 4 categories, but first, to understand the causes of homelessness, we must first look at the causes of poverty. Homelessness is easy to see because it's all around us, but mental illness, mental health challenges are something that can't necessarily be seen, though homelessness and mental illness often correlate, especially when we're working with our chronically and literally homeless populations. Now, homelessness is essentially broken down into these 4 categories. By HUD's definition, the literally homeless, the chronic homeless, which we'll essentially touch on today in its correlation with mental health and mental health services here in Michigan. Those who are imminent risk of homelessness. Now, these are folks who are kind of day-to-day behind more of your eviction category, folks that are at risk of being in that position. Then we have those who are homeless under other federal statutes, migrants, immigrants for a variety of different reasons, those coming out of the criminal justice system. And then lastly, we have those who are fleeing or attempting to flee domestic violence. Those who are looking for relief after violent encounters, if you will. The interesting thing is that today in post-pandemic America and here in Michigan, millions of us are living on the edge of homelessness, just 1 or 2 paychecks away from not being able to pay our rent or mortgages. And if we could go to the next slide. So, services that we provide that address this are called homelessness prevention. We work with a variety as the Housing Assessment and Resource Authority for Calhoun County. We work with the Coordinating Council of Calhoun County. We work with the state of Michigan, and we make sure we work with our local churches and community leaders in making sure that we prevent homelessness as best possible. So when we have calls, whether it be from 211, whether it be folks coming into our offices, or even being plugged into the network with other agencies as we engage our public, making sure that we can get folks, if they're literally homeless, rapid rehousing, homeless hotel assistance, some type of diversion so that we could step in and help them get into a place. That's what we do. If we could go into the next slide. Now, there's the other piece. There's the economic piece. With prevention, as many of us have certainly seen in these last 2 years, is the workforce has changed, the economy has changed in a lot of ways, and challenges have continued to affect populations in adverse ways. Now, while 13% of struggling Michigan households may live below the average national poverty level, another 40% are in a position called ALICE. Now, ALICE stands for Asset Limited, Income Constrained, but Employed. Now, these are a lot of our families, friends, neighbors, folks that are kind of just barely making it, but maybe in that position where, one emergency could put us in that detriment of being in a homeless category. So I'll give an example. A parent who's already struggling with the cost of childcare, for example, may have to pick up their child early because they get sick, but that parent relies on childcare so they can go to work and earn money. So that parent may then miss work and could lose their job. And this is counter to the fact that, according to our community needs assessment for Calhoun County, 40% of the pay for single moms actually goes to childcare. Now, the same could go for someone who, for example, can't afford a reliable mode of transportation. That head gasket's not looking too good, transmission challenges. If we finally get out of winter here, new tires. And if their car breaks down on their way to work, they could lose their job for not showing up or for showing up late. But with those socioeconomic realities, even before the pandemic, there have been a number of these factors contributing to homelessness in Michigan. And that's what brings us to our issue at play today in mental health, which is the other category, our chronically homeless. If we could go to the next slide. So, services, again, that we provide to address a lot of this are called rapid rehousing. And that's where agencies like Neighbors, agencies like the Housing Commission, and so many in our network, we come together, we provide vouchers. If someone needs an opportunity to get into transitional housing, or they're literally have nowhere to go, or like in our last category, fleeing domestic violence, we could get them to organizations that provide services specifically for that. But we also have emergency services where we offer hotel assistance and the opportunity to intervene. And that's where expanding the scope of housing services to human services is so important. And it allows us to open that door to not only economic health, but mental health and its direct effect on homelessness. And that brings forward our ideas and our approaches when it comes to permanent supportive housing. If we could go to the next slide. Now, it's important to understand that the stress that comes with homelessness also in turn can increase the risk of mental illness. Living without a home can increase fear, anxiety, depression, sleeplessness, and can lead to substance abuse as a coping mechanism. Right now in Michigan, the campaign to end homelessness will show you that just under 31,000 individuals experiencing that literal homeless category. While fortunately for our next generation, our 18 to 24 young adults, they're actually kind of showing a decrease. They're actually starting to get a little bit better when it comes to homelessness, which is good for Michigan. We can, of course, talk about high levels of racial disparity as well. And really, that's what brings us into expanding the scope of housing. Our issue. Now, while there's the issue around prevention, the issue around ALICE, the common knowledge that for many folks who are working, especially in a two-parent household, may not apply, may not qualify for a lot of basic assistance, things like food stamps, things like utility assistance, a lot of those day-to-day top 5 bills that we all talk about at the dinner table. Now, again, when folks are working check to check, we have almost half of Michigan in this ALICE population are greatly benefited by the opportunity to qualify for a lot of these human services resources, and they don't. It kind of puts them in that jeopardy when it comes to the risk of being homelessness. So the issue then would be, should we look forward to our politicians and our political leaders in putting together a bill to maybe raise that threshold. Let's say a family of four can't make more than $50,000 to qualify for food stamps. Let's change that to $60,000, for example. We open the door to tens of thousands more Michiganders that could then start getting a lot more of these resources available and be able to pay their rent, pay their mortgages, and get out of being at risk of homelessness. Now, that's what brings us to permanent supportive housing, the mental health piece. This is for chronically homeless and or homeless individuals who may be suffering with mental illness, where agencies like NIBC, like Summit Point, like the shelters, and all of us in partnership, we provide wraparound services and case management services to help these individuals while they're in receipt of stable housing, get the services and get the assistance they need to reach self-sufficiency. It buys us time. And the last piece, of course, would be legislative landlord incentives. The third issue, the third question that we should take home today should be, should we maybe look at biannual property tax abatements for property owners who rent to low to moderate income individuals and families, or who provide that permanent supportive housing? This is something that we've come to because in Calhoun County, we have about 14,000 homeless individuals, which is about 10% of the county. But we're adversely underfunded. Things are going to change now that a new supplemental budget is passed, and it's going to be our responsibility, good folks like all of you, good folks like us, in providing these services so that we can apply for these resources and tailor them the right way in identifying the correlations with chronic homelessness and mental health, and then providing that assistance the right way. If we can go to the next slide. If we go to the next one. Yeah, there we go. So in expansion of that approach in permanent supportive housing, I'd want to share that NIBC, we offer financial education, we offer case management, and we offer those good supportive services that have been critical components to the success of permanent supportive housing. This is number 2 in those 3 take-homes that we should take in this issue in our identification of the correlation between mental health challenges and chronic homelessness. And this is something that we should definitely look forward to, adhering to when it comes to fund development, when it comes to programmatic diversification, to really address these challenges when it comes to mental health and chronic homelessness. This process has also been successful in removing a lot of other barriers, because in permanent supportive housing, we have that extra piece along with the opportunity for stable housing, where things like childcare, those feature challenges, education services, job training, even substance abuse treatment are options that are inclusive in helping folks achieve and advance in that path to self-sufficiency. And that's why it's so important in its correlation with mental health and with literal homelessness. And NIBC is excited to be a part of a progressive way of addressing these type of human services and working with our mental health providers for a greater Calhoun County. If we could go to the next slide. So, in closing, we put together, the benefits of PSH through agencies like NIBC and through initiatives and through partnerships and programs in adherence to support for PSH in addressing this critical concern, this overlap with mental health challenges and chronic homelessness in our district. It starts with the physiological, with housing first, you achieve stable housing, you're able to stop, you're able to take a breath, you're able to have that stable roof over your head, regroup, you have that safety, you have that security. And then as we ascend in the pyramid, comes the love and belonging, the social piece, the barriers, adherence to the antisocial piece of homelessness start to diminish, which leads, of course, to self-esteem and then self-efficiency. And we're just excited to be a part of this process and be partnering with all of you in this through the development of community-wide initiatives adherent to PSH, we can definitely avoid the duplication of services. We can maximize resources in Albion, in our county, and in our state. And then we can heighten rapid rehousing and transitional housing and permanent supportive housing opportunities, and give us that time to really address a lot of those barriers adherent to mental health here in Michigan. So I wanted to close that, I know that these are very challenging times, but in those challenges, I find inspiration, and I'm inspired by this opportunity to work with all of you. So in the words of John F. Kennedy, if a free society cannot help the many who are poor, it cannot save the few who are rich. Thank you, and God bless. I'm gonna scroll up a little bit. My wife got me the nifty touch screen here. Yeah. So, Marquetta asks, does NIBC assist with programs that assist young adults that are basically couch serving and are not well prepared for independence? Yes, we do. In fact, I would say a good 15% of our clientele are in that 18 to 24 range. We're excited to see that not only here, but statewide, we've seen that trend kind of diminish. But we definitely have not only that, but we have the opportunity for vouchers. We have short term, but then we also have home ownership opportunities. We have rent to own opportunities where we can get folks into something called tenant-based rental assistance, where even now, while we have programs where we can help with COVID emergency rental relief, if someone is in a position where they're coming to NIBC because their rent, for example, is unaffordable to begin with, we have the opportunity to actually help that individual secure a down payment on a new, more affordable place. And in the meantime, provide them with the transitional option of hotel assistance for up to a week to get them to that point. And once individuals are placed, individuals are adherent to any of our rental supportive services programs, there's also the opportunity with us for financial coaching, financial education, and then, of course, the path to home ownership, which is at the core of our central mission at NIBC. Not only stable housing, but home ownership. So am I located locally, or do we need to travel to Battle Creek? No, we are actually located, we're located in Battle Creek, but as of the past month, this is actually going to be week 4 for us. We're actually located on Mondays and Wednesdays also at the Cram Building in Albion. So we get the perfect view, that big Coca-Cola wall, and we're here to serve you. We're operable the full day, full 8 to 4 on those 2 days, and we're looking at expanding. How does someone get a house by the end of the year? So that could depend on a variety of factors. So let's say someone doesn't own a home. Let's say it's someone that's renting right now. It begins with financial education. We come in, we get signed up with one of our financial education, financial counseling courses, and then we proceed with the rent to own options adherent to not only our properties, but also in partnership with the other agencies we work with through FHLBI, and that's the Federal Home Loan Bank of Indianapolis, because at Neighborhoods we're also a lender. And then that's how we begin that process to home ownership. It's twofold. It could also be the rent to own option. Now, if it's someone that already owns a home, I must suffice to say that in this economy, it's much easier. I'm seeing overbidding. I feel like I'm in California, excited for it to look like California as we proceed into spring. Do I still do down payment assistance for first-time buyers? Yes, we do. Not only that, we also expanded with our, of course, our financial counseling and financial education. But then we also offer the opportunity for microloans, so we can help with home repairs, windows, gutters, paint, supplies. We could help with $1,000 microloans as well, and more, depending on the issue at the home, specific for home repairs for homeowners. All right. Well, That is the questions I see for today. Again, everyone, it's been a pleasure. We're a little bit of my Easter colors today because I couldn't catch everyone yesterday, and just wanted to thank you and introduce Jamie Lewis and Tori Jones. Thank you, everybody, and have a good night.
Very succinct. Thank you so much. Thank you so very much, Mr. Arturo Puckerin. It was great to hear from you and to learn that now the Albion community also has access to those resources that can greatly relieve people who are suffering from lack of home, not having enough assets, being in the Alice category, and even those people that are just one emergency away from a really bad position and can use those microloans. So this has been awesome. And just as he said, I would like to now introduce two people who are going to share with us about two very important health conditions that affect so many people in our communities. I don't know anybody that doesn't have a family member, close friend, someone that's important to them that either has diabetes or has some form of kidney disease and needs to balance how to treat that, how to eat for that, how to have a lifestyle that now is centered around kidney disease or diabetes. So now we have two people that will talk to us about this, and it just gives me great pleasure. I'm going to first introduce Tori Jones. Tori is a member of the Macedonia congregation, and he comes regularly with his daughter, Shatori, and it has just been a great, great joy to see him manage his own condition. He's like a player coach. So he's going to talk to us as a kidney health coach. Tori was born January 8th, 1971. He is a graduate of Albion High School, yes, in 1989. Tori completed an online program through the Kidney Foundation, scoring 100% on the certification test. And as I mentioned before, he is a member of the Macedonia Missionary Baptist Church in Albion. I just also want to say he is a very strong advocate for kidney health and effective kidney treatment. And so I'm really looking forward to his insights. And yes, next, I would like to introduce Jamie Lewis. Jamie Lewis is a registered nurse and clinical manager. And Jamie has worked in dialysis for the last 20 years. As she mentions, it is half of her life. She started in the stockroom and worked her way up, and now she serves as the clinical manager for Fresenius Kidney Care of Coldwater, Michigan. Jamie enjoys her job because she's able to form connections with her patients and provide them with not just dialysis, but with respect, kindness, and compassion. So it gives me great pleasure to present these two presenters who are going to talk to us about wellness in kidney care and how to effectively manage kidney disease and diabetes and dialysis. Thank you so much.
Hello.
Hey, Jay.
Hey, how are you?
All right, all right, all right.
You know I talk too much, so maybe you should start.
Well, yeah, my name is Tori Jones. I've been a dialysis patient for the last 8 years. When you're dealing with your kidneys, you're dealing with so many different aspects of it, from diabetes to blood pressure to how you eat, how you drink. You know, you got to have a routine. You know, you have to base your life around it. And when I say you have to base your life around it, you have 3 days of the week where you have to sit under a machine for 3 to 5 hours to filter your blood because your kidneys don't work. And it can become mental, especially if you've been doing it for so long. It can become mental, but it's also how you carry yourself, how you take care of yourself, what you eat, what you drink, what's your fluid intake. Um, you know how they will have you look at a can. You have to check the ingredients on a can. I mean, you have to really be strict on how you take care of yourself because the things that you overlook can be real detrimental to you in the long run, as far as sugar, phosphorus, potassium. You know, these things that we don't look at because we've never heard of it being serious business. But I mean, it can cause cardiac arrest if your phosphorus is high, your potassium is high, your fluid intake, because you don't have no way of getting rid of fluid but through dialysis. So you have to have so many ounces a day. I mean, you have to have a routine to survive.
I think you did a great job of describing that, and you can give these people so much information that I can't. I think
Right.
that one of the hardest things, I guess I should introduce myself. Hi, I'm Jamie. Thank you for the awesome introduction. I have been with dialysis patients half my life, literally. This is the only big girl job that I've ever had. I love this job so much because these people mean so much to me. I'm not a person who really likes medical things, but I love my job. I love being invested in people. I love taking care of people day to day. I love that I get to develop a relationship with patients. Like Tori, for example, I was there one of his first days, maybe even his first day of dialysis ever. So, you know, taking this big, overwhelming diagnosis, this big, overwhelming process, breaking it down into small pieces, being a friend, being an advocate, being there for our patients. That is the entire reason we do our job. It means so much to all of us. We take it very seriously. They become like a family to us. For example, like I'm working in the cold water clinic now. I haven't seen Tori on a routine basis in years, but we still have a lot of mutual respect for each other, still very invested in trying to make sure that I can do anything that I can do. Being here tonight, anything that I can do for the patients, I'm all for that. So, like Tori said, it is a lifestyle and it is overwhelming. We have a lot of different puzzle pieces and a lot of resources because dialysis is one of those things that until you know about it, it's very, very overwhelming. But once you get into the dialysis world, you realize that it affects so many more people than you realize. I always joke that dialysis centers are like Dollar Generals. They're everywhere. You don't realize it until you're looking for one, but we are. It's a huge issue that affects so many people. Hypertension, high blood pressure, and diabetes are the main cause of kidney disease. So it affects a lot of people, and the numbers continue to grow because of people's lifestyle choices and things like that. People eating fast food, you know, not controlling their intake and stuff like that, stuff being easily available. It leads to being diabetic, and then that can lead to issues down the road if you don't control your sugar. So like I said, I can talk all night. I'm trying to make sure that I answer some of the questions that were discussed before we started. So if a patient, there is a question. Before you get to dialysis, how do you know if your kidneys are failing? Symptoms in stage 1, 2, 3, and 4. Great questions. So our hope is that before somebody gets to dialysis, that they've had interactions with a primary care doctor and a nephrologist, a kidney doctor. So we're hoping that by the time you get to dialysis, you have an access in place and things like that. Sometimes people crash into dialysis where they end up in the ER and, you know, they get the labs and they're not looking good. You get a catheter in your chest and we start dialysis, and that's a lot. So if we're doing routine lab work with your primary care physician, it can diagnose you with the different stages of kidney disease. And then there's different interventions that they can do to try and help maintain the life of your kidneys and things like that. There's many different steps. So they can set you up. You have the nephrologist, the kidney doctor. They can set you up with the social worker to try and get you resources. You need a ride for your appointments if you need someone to help you set up, you know, your lifestyle so it's conducive for kidney disease. Things like that, get you hooked up with a vascular surgeon. They're hugely important. Your dialysis access is your lifeline. If you don't have a dialysis access, you don't have dialysis, and it's very dangerous. So we take that stuff very, very seriously. So we're just trying to make sure that we have all of the best resources for our patients. And that continues when you're on dialysis or when you're not. So basically the different stages of kidney disease are based on your lab values. So there's going to be renal function panels. There's going to be urine output tests, not just how much are you urinating, but what is the quality of your urine? Are you able to get the waste in your body out via the urine? So we base your lab values on those stages. And then by stage 5 is typically when you begin dialysis.
Now also, you don't have symptoms that actually let you know that you have a kidney problem. You might happen to go get checked out, and maybe your doctor will give you, and because I didn't know until I was stage 3, and when I was stage 3, he basically told me, just watch your intake, watch what you eat, watch you drink, because when you're stage 3, after that, it's basically downhill. It's gradually slow, but 9 times out of 10, you're going to wind up doing dialysis. So if you get to stage 3, it's kind of a stepping stone to going a step forward, and 5. Then when you're 5 is when you're already prepared. They already have the fistula in your arm. It's already healed and then are ready for use. So there is stages, but you don't know until you get checked out.
Right. You don't necessarily know. And
Right.
sometimes you don't necessarily realize how badly you're feeling because your body just adapts. You can only adapt to so much. But I think that, like you would say, don't you think that after a couple of weeks in dialysis, you didn't realize how bad you felt until you actually started to get some dialysis and started to get some of the fluid off and actually feel better?
Exactly, because it takes all the excess water. Once you get it done for, I say, the first 2-3 weeks, you can feel the change. You can see all the excess water you had on your body is taking off, and you actually feel a whole lot better. But now that's when the stipulations come in. That's when your fluid intake. That's when you have to check your levels. That's when you got to read labels. That's when what you eat, what you drink, what you take in plays a major part to your body. Because if you bring it in pop and all that sugar build up, that's not doing nothing but clogging your heart, your lungs. And I'm gonna tell you, when you have a bunch of excess weight on your body and you can hardly breathe, that's like the worst feeling you ever want to feel. Because your chest can't compress. You feel like your heart is tied in because you have so much fluid in your body and there's no way to release it. And the only way it can be released is dialysis. Because after you go a certain amount of time of doing dialysis, you can't urinate. And that's when the fluid buildup is really cautionary. You got to be careful of your fluid intake.
And dialysis is not, like you said, dialysis is not just your treatments. That's a lot. That's hard. We have people who are in our centers 3 days a week, 4 to 5 hours. I mean, that is a huge commitment. But then once you leave the clinic, your entire lifestyle is designed to maintain the best levels that you can. So that way you can be as healthy as possible. And it's kind of, I think that you would probably say, Tori, that like it's up and down. By the time it's time for dialysis again, you're starting to feel low. You get your treatment, that kind of wipes you out, take a little rest, start to feel good again, and then it's back and forth. Yeah. So I think that that's challenging too. We got a couple of good questions in the chat. What kind of financial assistance is available for kidney patients? Any dialysis patient is automatically eligible for Medicare, no matter their age. So that helps take care of your dialysis treatments. That also includes a bunch of your meds. It's considered like a dialysis bundle. So we try to make sure that all of those things are taken care of for you. That also gives you access to transportation for dialysis treatments and things like that. And then there are just a ton of resources. In Kalamazoo, there's a Kalamazoo Renal Support Group. It's just a group of dialysis patients that are like, hey, you know what? This sucks. What can we do to make it better? And they have committed their entire lives outside of dialysis to helping take care of patients. They will give rides. They will financially support. They are an amazing, amazing group of people. And we try to really support that. There's the National Kidney Foundation. There are so many resources. And like I said, we have a social worker at every clinic. There's so many ways that we try to help support financially, because that's a huge burden, and not being able to work or having an altered schedule. We try very hard at our dialysis center. Sometimes we are open late in the evening just for one patient, because if one patient wants to go to work, we're going to work that out for you. So we try to be as accommodating as we can. We know it's hard when you're taking 12 to 15 hours out of your week. If I get a kidney, do I stop diabetes? That's a really good question. If you get a kidney, if you're diabetic and you're trying to get a kidney transplant, they will try to do a kidney and a pancreas transplant at the same time, which is magical. It is a huge blessing. So you can actually cure your diabetes and your kidney disease all in one transplant operation, which is amazing. Drinks like with electrolytes, okay, if you have kidney disease, like Gatorade, Powerade, Body Armor, no. No, they are so dangerous. So those drinks have potassium in them. And like Tori said, potassium is the biggest electrolyte in your body that's not controlled when your kidneys don't work. I am telling you, it can be incredibly dangerous. Cardiac arrest. I mean, I cannot stress that enough. Like Tori said earlier, watching your potassium levels, they say 3.5 to 5.5 is normal range for a patient. And the kind of way to remember it is they say 8 is the gate, heaven's gate. So if your potassium gets too high, it builds naturally between dialysis if you don't have the urine and the body balancing that out. So very, very dangerous, especially with drinks like that have so much potassium in them.
Right. And so what is worse, salt or sugar? Both.
Yep.
Salt and sugar, because you're dealing with diabetes and you're dealing with a high blood pressure. And salt contributes to the high blood pressure. Sugar can to the diabetes. So both of those is dangerous. And see, that's the top two that can cause kidney failure. The salt and sugar, which would be diabetes and high blood pressure.
Did you see your question? What is the atmosphere of the clinic, and how do they help you transition from no dialysis to dialysis?
To be honest with you, it's really a stage, because you're dealing with all ages. You're dealing from ages 15 to 90, 80, 90. I've seen people come in and they actually feel this is their last stop. They feel, okay, well, this is what's keeping me alive, so I'm just going to come here. Then you got some who really is trying to get a kidney. And see, my case is I'm trying to get a kidney, but mine is a little bit to the left because I'm also raising an 8-year-old daughter. So I have to maneuver and bob and weave to take care of her, go to dialysis, make sure she's okay. So it's kind of different strokes for different strokes for folks, because everybody don't have kids, and the majority of our patients is like 50 and 60 and over. You're not going to see too many, young, like 20s, 30s or whatever. It's usually a lot of older people, whose kids is grown and gone. So it's kind of different when you're dealing with all different ages. But the atmosphere is wonderful. I love everybody in there. The atmosphere is wonderful, but you have to make it that way. You have to make the best of it, because you're sitting in there. Like, I sit for 5 hours. So I have a routine, though. That's how I get through my day. Every time I go in, I have a routine. But it also helps to have people you can talk to. The people sitting next to you, or the nurses or whoever. That also helps out. Because, it can get boring, but you have to make yourself, and you got to think about, this is my lifeline. I still want to be here. So you got to make it work. You have to make it work. And there's people coming there who just gave up. They just couldn't handle the mental part of it, because for one, they got to be there 3 times a week, 4 hours each time. Some of them so scared of needles. Some of them just can't take it, the mental. They just can't believe that they're on dialysis, and they just give up. I've seen that also. I've seen so many different ways of people handling it, but it's all up here. Because at the end of the day, it's if you want to live or not.
No, I think what you're saying is it's very important. And like I said, we can advocate for the patients. We try to make it as enjoyable as possible, but it is not enjoyable.
It's
You know,
real.
we can enjoy each other's company. I think especially with COVID, when like the world kind of shut down and everything got turned sideways, we were so grateful that we still had each other. And you know this, there are some patients
Yes.
who live in a nursing home. We are their family.
Yeah.
That's it for them. They wouldn't go anywhere other than the nursing home if it wasn't for us.
Right.
You know, they don't have family that visits, or they just don't have family. So coming in and seeing the same people all the time, it means so much. It's so nice that in the world of craziness that you have your same patients, your same caregivers. It means the world to all of us to have each other. It really does. It becomes a family. You know, you still be professional and you take good care of your patients, but you are their family. There's no way around it. You can't do this job and be with these people all the time and not be invested in their future and want the very best for them. You know, like Tori has a daughter. I know that. I remember when she had a Minnie Mouse phase and she wanted that for her birthday and stuff like that. Like, this is the thing. These are the things you talk about to pass the time and to try to make the best out of a hard situation. You know, I always joke, I am brave about the needles because I am putting them in somebody's arm. If it was my arm, I would not be brave. I would be putting all the numbing cream on and having a fit and, you know, don't talk to me until it's done. I get it. I wouldn't want to be in your shoes. So the most important thing for me is to try to take whatever I can do to make it better. And that's what I'm here for. I'm there for that. I'm there for the patients to try to make it better for them. And like Tori said, it's a lot to get a transplant. There's a lot of testing. There's labs. There's approvals. There, even once you're on the list, sometimes like we had a patient who was like second on the list. He got like 3 calls and, you know, get ready, pack your bags. We're ready to go. And it just didn't work out. I mean, he finally got a kidney, but that is so devastating. Getting the call and thinking this is it, we're going. And then it's not right.
Yes.
The awesome part about the transplant list is once you get your transplant workup done, they backdate your start time on the wait list to whenever you first started dialysis. So it takes a long time to make process, but once you're on the list, you get backdated to the beginning. So I always try to tell patients that, like, don't lose hope, don't get discouraged. As soon as you're on that list, you're on it, and you have been this entire time. So, you know, I really think that, don't mean to be cliche, but I think that everything happens for a reason. I think that I ended up in this job because I have a heart to take care of people, and I'm ridiculous. So I enjoy, you know, singing and dancing and making it as fun as possible. Not that we don't take what we do seriously. It is incredibly important to us. It is so important to us to keep these people healthy and safe and give them the best quality of life possible, but also while having as much fun as humanly possible while we do that. I think we can have the best of both worlds for sure.
Yeah.
Oh, Marquetta, I miss you too. I know you miss my dancing. No one misses my dancing. It is not good.
Yeah, but see, as you do it for so long, you just create relationships, because these are the same people you see every other day that's sitting next to you, across from you, whatever the case may be.
Mm-hmm.
Everybody speaks to each other. You know, everybody need encouragement. You know, sometimes we can sneak treats in, you know what I'm saying, just to get everybody through. You know what I'm saying? I mean, you really get attached, you know, because everybody knows everybody. And this is not just, this is Monday, Wednesday, and Friday, and Tuesday, Thursday, and Saturday.
Mm-hmm.
So these are 6 days of people's lives, right? You know what I'm saying? In one spot. So we all have to get along. We all got to make it worth being there. Because if you feel like you ain't supposed to be there, you're going to give up.
Mm-hmm.
And you see that a lot. A lot of people give up because they feel, okay, this is the last. This is it. This is what's the last thing that's going to keep me alive. And see, them the ones that you got to talk to and keep uplifting and,
Mm-hmm.
you know, whatever the case may be. I'm a jokester. I joke around. I try to make people laugh, because at the end of the day, we sitting there with 2 needles in our arm, watching TV for 5 or 4 hours, and just sitting there. You know what I'm saying? That can get to people. You know, that can really get to people. 'Cause I've seen people actually be there 10, 20 minutes and they're ready to go
Mm-hmm.
because they can't take it. They can't sit there like that. You know, they can't take the needles in their arm. They can't. It's something that's really boggling their mind to where they don't want to be there, but they got to understand this is your lifeline. If you don't have dialysis, you're not going to be here. And some people really disregard that, and some people don't come. They miss out. They might miss a day, miss 2 days. And if you miss one day of dialysis, best believe that that following day, you're going to wish you didn't.
Mm-hmm.
Because a buildup in, just imagine a whole bunch of garbage in your body and you can't release it. Everything you ate, drank, whatever the case may be, you cannot release it. It's all in your body. It's all a buildup. And you got to wait from Monday to Friday to get it taken off of you. That's like the worst feeling you ever can have. That's like walking with plastic bags in your body because everything you've drank and eaten is still in your body. You know, that's your lungs, your heart, your stomach, your chest. This is all the stuff that hasn't been released yet. So that's toxins from what you ate or what you drank. You know, so dialysis is real important for people with kidney failure to release the fluid, the toxins. It filters your blood. It takes the old blood, put clean blood back in. It makes you feel so much better, so much better. But if you don't go, you're going to wish you did go. You know, so there's the ups and downs of it. But at the end of the day, dialysis is a lot of people's lifeline here in Albion, Michigan. A lot of people's lifeline throughout the community. And you know, I'm the person that's trying to get people to see because it was getting slept on. A lot of people didn't know how many people just in Albion was on dialysis. Just in
48
Albion.
It's just in Albion.
Yeah, just in Albion. The building is almost full just of Albion people. You know, so I mean, it's the life that you got to take it serious. You have to take it serious. You have to if you want to be here.
Absolutely. And I think that, you know, having support from your community, having support of others. And I just wanted to touch on the fact, like you said, we are all there for each other. But inevitably, like you said, a lot of our patients are older. A lot of patients, dialysis is their last stop. And I think that, you know, we are a community that comes together and we rally, but we are also a community that mourns sometimes. You know, if we lose a patient, it's not just hard on the other patients, it's hard on the staff.
It's hard on everybody.
It's awful. Yeah. It's a terrible thing. So I think the more that we can do to raise awareness and raise support, you know, it takes a village in every single aspect of life. So the more that we can have, you know, support our patients, support our community, I'm all for it. I'll make sure that everybody has my contact information. If there's anything I can do to help enlighten or support or take some of the burden off, sometimes just having somebody to talk to makes a huge difference. I am always available. I'm always here for that. And I think that we're over our time. So
For sure.
Is there anything else specifically?
Any more questions?
Yeah, I'm trying. Good treats for dialysis patients. Rice Krispie treats are really good because they're not high in phosphorus or sodium.
Vegetables,
powder, and not make it gross.
Fruits, different kind of fruits, different kind of vegetables.
Careful, yeah.
If you eat candy, no sugar.
But don't eat fresh that or then you'll have diarrhea.
Right. You know, just but a lot of vegetables. A lot of, you know, not dark green vegetables, but stuff like cabbage, lettuce. Stuff
you know what
like
Dr. Crushy says, bread and water and easy on the water.
Right.
I think we answered all the questions. Thank you so much for this opportunity. Like I said, I truly mean it. If there's anybody who would like to speak more with me, please let me know. I'm always just a call or an email away.
Yeah. Thank you.
Thank you. Miss you.
Miss you too.
I will be introducing Allie Rogers. Allie Rogers is a community nutrition instructor for the Michigan State University Extension in Calhoun and Eaton County. She has been with MSU Extension for 3 years. Her background is in nutritional sciences with an undergraduate degree from Michigan State University Extension. Allie is finishing up her Master of Public Health at Saginaw Valley State University next month. She is passionate about working in the community to build and foster healthy behavior changes. When she isn't teaching about food and nutrition, you can find her reading with her cat, Goose. Ladies and gentlemen, Allie Rogers.
Hello, everyone. Thank you so much for that. I am so excited to be here with everybody, even though we are at a distance. I am really stoked to be here. This is my first time using StreamYard, and I'm kind of excited about it. It's pretty sweet. So I do ask for a little bit of grace and flexibility navigating it if I don't have everything perfect. But again, my name is Allie Rogers, and I am a community nutrition instructor for MSU Extension, which is just a really long title that means I like food, I like to talk about food, and I think it's really important that we have this good understanding of how food, nutrition, physical activity all plays a role into our overall wellness and physical wellness and well-being. And so I really appreciated being able to follow up from that last conversation and presentation, thinking about our health and some of the things that we can do and how important that is. So today we're going to talk about some different types of foods, specifically how we can decrease salt or sodium, added sugar, and saturated fats. 3 things we tend to overconsume. So we're going to pull up my slides here, and you can skip this because this is about Zoom and we're not on Zoom. Go ahead. There we go. Decreasing fat, salt, and sugar. If you were with us last year, the year before, and you've seen me before, I appreciate y'all's coming back again. If you haven't seen me before, I am so happy that you're with us again this year. And so I thought, well, let's do something a little bit different and look at the whole picture. So we have here on the screen our My Plate. We use this as a way to kind of determine what foods do I need and in what amounts am I supposed to be having. If maybe you want to think back a little bit, we used to have the My Pyramid, if you also remember that. This kind of ages me a little bit, but My Pyramid hasn't been in circulation for about 11 years. We've been using the My Plate for a while, but we won't think about that. But we have these 5 food groups: fruits, veggies, grains, dairy, and protein. What this really shows us is that if I eat these foods in this amount, I'm going to be the most likely to get my essential nutrients. And essential, we've been hearing that word a lot for the last couple of years. It means I gotta have it. These are the things that my body needs to function at its best, to feel its best. And while we have our essential nutrients, we also have nutrients that are not so essential for us, or ones that we have to be really mindful about how much we have. And those 3, you guessed it because it's on the screen, are fat, salt, and sugar. So let's dive a little bit deeper into that. Go ahead and go to our next slide, please. Of course, MSU Extension does not discriminate, and we are so excited to be able to be here with everybody and are inclusive and welcoming of everyone in all communities. Next slide, please. If you get the chance, we will be sending out a survey link, or you can take this little screenshot of a survey here. This helps me for 2 reasons. 1, for my funding to continue to offer my programming at no cost, and 2, to prove to my bosses that I did something today. If you want to fill it out, feel free to. All of the information is confidential and completely voluntary. But let's get into the good stuff. Looking at salt, fat, and sugar. Three things that tend to be kind of the most addictive food stuff. And a lot of times I hear, well, the tastiest of stuff. So where do we find these high amounts of fat, salt, and sugar? A lot of times they're going to be in processed foods, packaged foods, convenience foods, junk foods, fast foods, things that we kind of know aren't always the best for us. And so you'll see on the screen, I've got a little bit of salt there. I've got a sugary beverage. And in the center is actually a picture of what fat kind of looks like in our bodies, right? It's kind of this yellowish, orangish color, kind of funky shaped. And so, excuse me. So there are some good fats and some not so great fats. So I don't want us to get hung up on it and be like, it's always bad. Just like everything else, it's all about balance. It's all about moderation and being mindful. So I like to think of it as heart healthy and not heart healthy. So if you're following along with me, you can make a heart with your hands, put it over your own heart. When we think of unsaturated fats, those are heart healthy. Our heart loves it. It's a happy heart. But when we think of saturated fats or trans fats, we take that heart and kind of break it because then our heart gets sad, because those are not so heart healthy fats. And fats are actually an essential nutrient. We use fat on our body to keep us insulated, which is why today, as I'm looking outside and it is still snowing outside of my home, which is wild, I didn't freeze to death when I walked outside because I have that insulation. It also helps to provide some protection for my organs. If I bump into my desk, I'm not going to immediately impale my liver because I have some cushion. But like I said, just like everything, moderation and balance is key. So let's jump to our next slide. What we'll talk about is those differences between saturated, unsaturated, and trans fats. We're going to get a better understanding of what our recommendations are for salt and added sugar, and then practice this knowledge on these different types of fats, salt, and sugar. Go ahead and go to our next one. What I want us to think about is to not fear it. Like I said, we've got heart healthy and some not so heart healthy. And I know that this is really small, but I will be sending out to our great folks that are setting this all together some different handouts and resources to be able to provide to everybody. So those unsaturated heart healthy, but trans and saturated not heart healthy. A really easy way to think of how to identify these are that trans and saturated fats are going to be solid at room temperature. So think about some of those different fat sources: butter, margarine, shortening, right? Like cooking shortening, Crisco, even coconut oil, the fatty cuts of meat. You get a steak, it's got that marbling in it. Those are going to be saturated or trans fats. The ones that are liquid at room temperature, olive oil, vegetable oil, canola oil, are going to be those unsaturated fats, or the oils that we find in things like nuts and seeds or fish and seafood. Maybe we've heard of omega-6 fatty acids or omega-3 fatty acids. Those are those heart healthy ones. So I don't want us to immediately fear it. And of course, I'm never going to tell anybody you can't ever have any of these things. Like you can't ever have a hamburger or French fries from your favorite fast food place. I just want us to be able to identify when and how much we should be having. Next slide, please. So how do I figure this out? Because you're probably like, okay, Allie, you just told me I need to limit these. I need to watch out for it. How do I figure that out? Well, we have our nutrition facts label. And so maybe you've seen this. I'm imagining that everyone has seen one of these at one point in their lives. And so we actually have a new nutrition facts label as of last year, which might not be very exciting for you. It's very exciting for me in the nutrition world to get these new ones. And there's a few different updates on here. So we'll notice we have our total fats, and underneath there, it's breaking down between saturated and trans fats. because we don't need them, it's really nice to have them labeled on here so that I can identify them and I can see exactly how much I'm having. For this food, we only have 1 gram of saturated fats and 0 grams of trans fats. Pretty low, so that's pretty great for us. I'm going to skip us down a little bit to our sodium or salt. We might use those terms interchangeably, but our sodium is essential, but I have to be really mindful about how much I'm having. We really only need about 1,500 milligrams of salt in a day, 1,500 milligrams, which if you can see my picture still, it's kind of about the size of the tip of my pinky. It's not that much salt. I can think of a few fast food restaurants that definitely have that much salt on just one large French fry, right? So we have to be careful about that. When we have too much salt, that can lead to things like dehydration, swelling, or increased risk for heart disease and high blood pressure, some pretty serious things. So we can look here at our nutrition facts label to see how much we're getting in our food. And then our very exciting change to the nutrition facts label is the addition of the added sugar list. So before it used to just say sugar and we didn't know what was natural and what was added. Now it has to tell us what is added. So what's the difference between a natural sugar and an added sugar? A natural sugar, kind of what it sounds like. It naturally occurs in that food. And added sugar is added. So think about an apple. I got an apple, I take a bite of it, it's sweet. I didn't do anything to it, right? I didn't change it, I didn't inject anything into it, but it was naturally sweet. So that came with its own sugar. However, if I take that apple and I make myself an apple pie, I have added a lot of sugar in there that did not originally come with that apple. So that's what we're going to consider those added sugars. And we don't need added sugars to survive. We get plenty of natural sugars from fruits and veggies and whole grains. We don't need the added ones. Having too many added sugars increases our risk for things like type 2 diabetes, heart attack, high blood pressure, unintentional weight gain, cavities and tooth decay. So we really want to be mindful and watch those things. So now our nutrition facts label breaks that down and tells us how many total sugars we have, and out of those total, how many of them are added. So if we look here at this specific example, we've got 12 total sugars. Of the 12, 10 of them are added, which means that 2 of them are natural. Most of the stuff in here of the sugars, all added sugar, and that adds up fast. Something to be mindful of is that everything on this nutrition facts label only accounts for 1 serving size. And in this food, a serving size is 2/3 of a cup. You can actually use your hands to measure. So if we can stop sharing the presentation for a second so everyone can see my video. Perfect, thank you. So you can have your fist. Your fist is about the size of 1 cup. If your fist is a little bit bigger or smaller, it's gonna be a little bit different, but about 1 cup. Front of your fist, half of it would be about a half cup. You can do thumbs up to measure tablespoons. So 2 thumbs up, 2 tablespoons. And the palm of your hand is about 3 to 4 ounces. Same thickness. So usually we'll measure like a piece of meat or protein, so like a piece of chicken or a steak or something, 3 to 4 ounces this size. So these are handy ways, full pun intended, to measure out food. All right, we can go back to our presentation. So we can do that so that we know kind of how much food we're having. So for this made up food on this label, 2/3 of a cup is going to be a little bit smaller than the size of our fist. So if I was to eat 2 servings, I have to multiply everything here by 2. Go ahead and go to the next slide for me. So what I want us to think about with this is this red light, green light, yellow light, or go slow, whoa, how we identify these foods. So we've already looked and we know we want to lower added sugar, saturated trans fats, and sodium. We know we can read our nutrition facts label to figure out how much is in those foods. This is another helpful way for us to decide, is this a food I should be having all the time, sometimes, or every now and then? So our green light foods are everyday foods. These are foods that I want to have all the time, multiple times a day. The slow/yellow light foods, these are more sometimes foods. These are the foods where I'm going to start being a little bit more mindful of how much, how often. Maybe I'm having these once a day. Maybe I'm having them a couple days a week. But I'm really starting to think about that portion size. And then our red light foods. These are those whoa foods. These are the foods where I am moving back and I'm saying, okay, how much am I having and how often? These are definitely going to be those things that are a lot higher in those added sugars, fats, and salts. So think about treat and luxury foods, maybe celebration foods, candy, cake, sodas even. We want to be mindful about those. Not only are they high in those added sugars, fats, and salts, they're also low in some of those other key nutrients we need, like vitamins, minerals, protein, the heart healthy fats, fiber, which helps our digestive system and can even help to lower cholesterol. So it's really kind of important to look at the whole picture with everything. All right, let's go over to slide number 17, please. Perfect. So one thing that we want to do when we're thinking about healthy eating and what we're putting into our body is also how we put things out of our body, what we take out of it, the energy that we're using. And so if we talk the talk, we should probably walk the walk. So we're actually going to do some physical activity today together. You are by no means required to do this with me, but I am encouraging you all to do it with me. And we're going to do some learning as we do it. So you know your body best. If something hurts, it doesn't feel comfortable, you want to modify it, change it, take a break, whatever you want to do, feel free. But we're going to do a little bit of activity as we go through those different foods that we have on there. So if you think a food is a go food, you're going to march in place. March in place. If you want a little bit more, you can go ahead and run or jog in place. If you think that a food is a slow food, you can do a forward fold and touch your toes. And then if you think a food is a whoa food or that red light food, arm circles. You can also do these in your chair if you don't want to get up, and you can just modify it. So let's go back to that screen again, and let's see those different foods that we have. So let's think about orange juice. What might we think orange juice would be? So if it's 100% fruit juice, we can count that as a go food because it's made out of fruit. I've got no added sugar in there. There's probably not any salt, and it's not going to have any of those saturated or trans fats. But if it ends up being one of those fruit juices that's only 15% juice, and it's mostly added sugar and water, then go into our toe touches. It is going to be a slow food. What do we think about sports drinks? Sports drinks, they're geared towards athletes. What do we think? So these are actually going to be a slow food for us, a slow and almost whoa food. Something to think about with sports drinks is that they are geared towards athletes or people who are exercising a lot. They're really built up with electrolytes, one of those being salt or sodium. So if I'm exercising a lot and I'm sweating and I'm losing electrolytes, then yeah, I definitely want to get some more of those. But if I'm just hanging out at the couch maybe just watching Netflix, probably don't need to be replenishing my electrolytes as much, right? Of course, it's going to be different for every person depending on different things, but that's a really easy way to lower salt. What about coffee? And when I say coffee, I want us to think about like those super fancy drinks you get at Starbucks or wherever, you know, some sort of frappe or, you know, cappuccino or whatnot. Those are going to be whoa drinks for us. So first, let's think about the coffee itself. Coffee jam-packed with caffeine, as long as it's the caffeinated kind, which dehydrates us. So it's not even counting towards the water that we need every single day. And then think about all the other things that are going in there to some of these really fancy drinks. We've got whipped cream, caramel, chocolate drizzle, probably full fat milk in there, and that adds up. I have seen some of those fancy drinks have upwards of 84 grams of added sugar in them. 84 grams. And we'll look in a second as to how much that really is for us. Lastly, water. What do we think about water? That one's easy. That one's a go food, right? That is something we need. It's an essential nutrient. We've got to have it. So how much water do you need every single day? It's kind of tough. I've heard a lot of different things about it. The old recommendation used to be 64 ounces or like 8 glasses in a day. But we realize that everybody is different. And if our energy needs are different and our exercise needs are different, then our water needs should be different. So what we need is half of our body weight in ounces. Half your body weight in ounces. So if somebody weighed 200 pounds, that would be 100 ounces. I know you're like, this is nutrition and food. Why are you making me do math? Math is everywhere. You'll never get away from it. But half of your body weight in ounces every single day. Water is so important for us. Our bodies themselves are about 65-75% water. We're kind of like mini walking lakes moving around. We got to make sure that we're replenishing that and drinking enough. And things that have a lot of salt, caffeine, added sugar actually dehydrate us. And they're not counting towards our water consumption. We got a question in the chat. What about half of what my body should weigh? And there was an LOL in there. We got to be honest with ourselves and we've got to get half of what our body does weigh, right? Or as close as possible, right? If you're off by 5 or 6 ounces, that's fine too. What I want to encourage us to do is to get as much as possible. And I do know that it can be really difficult. If you need 100 ounces every day and you are only having 50 ounces right now, making that jump from 50 to 100 ounces can be a big leap. It takes about 21 days to form a healthy habit. So it's okay if you don't want to do that or can't quite do that in one big leap. Start by adding 1 extra glass of water or even just a coffee mug of water, right? Each day, add a little bit until you get used to it. Because also, you're going to be making more trips to the bathroom until your body gets used to it. But I like to think of that like every time I have to go to the bathroom, I have to get up and walk and go there. Then that's exercise, right? 2 birds, 1 stone. Ooh, Marquetta, this is a great question. What if I hate water? So yeah, what if I just don't like water? Or I just get tired of drinking it? There are plenty of ways for us to mix it up and not make it super boring. So obviously we can just drink regular water and that's perfectly fine. But I can also do flavored waters as long as I'm making sure that it doesn't have any salt or added sugar. It's going to count towards my water consumption. I can put fruit in my water. You can do like lemons, limes, apples, mint, cucumber, make it not taste like nothing, right? Because water doesn't really have a taste. You can also make your own fruit soda. So if you find yourself drinking a lot of soda and you're like, I want to drink more water, because soda doesn't count towards water either, we can do half 100% fruit juice and half carbonated water or fizzy water. And then you're making your own sort of fruit soda, and you're getting one full serving of fruits in there because it's 100% fruit juice, and you're getting an extra glass of water in there. And you don't even notice because it tastes really great. So those are really awesome ways for you to get more water in. All right, now I want us to go to slide 22. Let me check our time. Okay, we're doing great. So I like to bring this up, and if any of you had seen my presentation 2 years ago, which feels like 20 years ago, when I had brought the sugar in person and we looked at this, we looked at all those different sugars and how they're in like our sodas and energy drinks. This is a list of different names for sugar. So there's a lot of names for sugar. There's something like 70 some different names for sugar. But the way our body breaks it down is still sugar, you know, no matter how fancy the name is. So whether it's agave nectar or it's brown sugar, our body is kind of recognizing it the same way. Excuse me. And some of these do sound pretty fancy, right? Like fruit juice concentrate. Well, that sounds healthy because it says fruit juice. Or date sugar, even beet sugar. It's coming from beets, it's coming from dates. It's got to be good for me, right? It's still an added sugar. Fun fact though, most of the sugar that we get here in Michigan, like baking sugar, is made from beets because we got a lot of beets. Michigan grows a lot of beets. We got a good climate for it. So it doesn't really matter what the source is, it's still a sugar. Another easy way to identify if something is a type of sugar is if it ends in OSE. So we've got dextrose, galactose, glucose, sucrose, sucralose, lactose, maltose, all of those, they end in that OSE. That's also going to be a really easy way for us to identify if this is an added sugar. So we can look at our nutrition facts label and it says how many added sugars, and then we can look at our ingredients list to see what added sugars am I getting in here. Because unfortunately, food producers, their main goal is to sell us the food, to sell us the product, and it's not necessarily our own health that is their main goal. So as the smart shoppers and the cool consumers, we have to be the ones to know those different tips and tricks that they have and make the best decisions for ourselves. All right, I do want to go back to slide 20. Perfect. And I know it's a little bit small, but I'll read through most of it. So again, we've got these added sugars. We know that it's different from that natural sugar, and we want to be able to limit that. And so we can kind of see here on the right-hand side, the way this added sugar adds up. So we know first, it's not essential. We don't need added sugar. If you don't need any added sugar today, that's perfectly fine. Your body didn't need it. If you had some, that's also okay because we can work on it. We are not recommended to have more than 50 grams, or I'm sorry, yes, 50 grams or 12 and a half teaspoons of sugar. So 50 grams, which is the equivalent of about 12 and a half teaspoons of added sugar in a day. We're not going to go over that. So let's look here on this right-hand side. We've got ketchup. We've got our cereal, flavored yogurt, and then a chocolate bar to see how much added sugar is really in there. So of these things, just the ketchup, 12 of those calories come from added sugar. In our cereal, 48 of those calories come from added sugar. In our flavored yogurt, and yogurt, we think like, well, that's healthy. That's a dairy food. 72 of those calories come from sugar. And our chocolate bar, 74 calories come from sugar. Not that surprising with the chocolate bar, right? Because it's chocolate. If we were to have a piece of chocolate cake, 196 calories come from those added sugars. That quickly adds up. On average, most people here in the US are eating about 3 to 4 pounds worth of added sugar every month. 3 to 4 pounds of added sugar. So let's think about that. We had 3 pounds in a month, and there's 12 months in a year, and we know that it's not essential. We don't have to have that. That's like eating 36 pounds of something we don't even need. 36 pounds in a year. That adds up really fast. And remember those things that we talked about that are increased risk, right? Increased risk for unintentional weight gain, cavities, and mouth issues, increased risk for heart attack, high blood pressure. So if we can cut down on our added sugars and cut down on our salts and our saturated and trans fats, we can help with reducing our risk for some of these things. And overall can also help us to feel better because we can fill our plates up with more of those other key essential nutrients like vitamins and minerals, proteins, fiber, and water, of course. So with that, I'm sure that I have ruined plenty of foods for people, but I hope not. Again, I'm never going to tell anybody you can't ever have anything or any of these foods and you can only eat lettuce and carrots and apples. No, we should still have those things. It's all about moderation. How often, how much. We can use that traffic light, that go slow, whoa method of deciding how much and how often should I be having these foods. So with that, are there any last thoughts, comments, questions, compliments, your credit card numbers? I'll take any of them. I'm kidding, but any questions? Ooh, what about coffee with no cream or sugar? Great question. So coffee, again, if it's caffeinated, will dehydrate us. But if you're like me, you still kind of need a cup of coffee to get you going in the morning. And so a better option to reduce some of that added sugar and saturated fats is to either go completely black coffee, nothing else in it, or you can get low-fat milk or a milk alternative that's higher in protein. So you're getting more protein, and you'll also be getting some calcium, vitamin D, and potassium in there. So that's going to help a little bit. And then you can pick the ones that have no added sugar too. Does water flush fat from your body? So water doesn't directly just take the fat out of our body, but water is going to help us digest food better. It's going to help us metabolize that food better and transport our nutrients throughout our bodies. It also helps us to feel more energized, which can help with physical activity and using up that energy. So when we're physically active, we can tap into our stored energy, which is stored as fat, and use that up. That's a really great question. Ooh, young big questions. What about diet sugar or sugar alternatives? Or what if I have diet soda instead of regular soda? So it's not going to count as regular added sugar, but that also means it's not counting towards like our fruits and veggies. So it's not like, okay, well, it's a sugar alternative. I could eat as much as I want. I still need to be mindful about how much and how often. But if that's a way to help you reduce your added sugar, then that might be the way to start out until you can get more comfortable and more used to different foods or beverages that don't have any added sugars or alternative sugars. And if you find yourself drinking regular sodas and you're like, I want to drink more water because the lady on the screen said I should be drinking half my body weight in ounces, then maybe cutting back from regular soda to diet for a while is the option that works for you. Still trying to get as much water as possible, but if that's what helps you get there, then that's what helps you get there. We do have a good question. Are there certain foods to eat more of if you are anemic? Yes and no, but I don't have a super great answer for that. And I would recommend that you talk both with a physician and a registered dietitian so that they can work with you specifically to understand exactly what your levels are, because those needs are very specific to you. So I know my answer is not great, but that would be the best option. All right, let me make sure I got through all the questions. Ooh, how do you compare different sources of calcium, like 2% milk, cheese sticks, etc.? So we can use our nutrition facts label. And if we're actually able to go, let's go to slide number, go ahead and go to slide number 15. Beautiful, perfect. So this actually is an older version of the nutrition facts label, but it has very similar information. So you can compare, you'll find the calcium down at the bottom under that second large black line. And on the new nutrition facts labels, it's also down there as well. So that's going to give you your percent daily value. So if you eat this food in this amount, you get 4% of the calcium you need, and you'll need to find the other 96% someplace else. So when you're comparing different things like cheese sticks and 2% milk, we can, one, just compare the calcium, but there's a lot of other moving parts too. So you'll want to look and see, okay, well, I know I might get more calcium here, but is the other option higher in salt? Which option gives me more calcium but less added sugars? Or which one has the most calcium and the least amount of saturated fats? So that's a really great way to be able to compare those things. When we're looking at different types of dairy foods like 2% whole or skim milk, the big difference isn't the calcium. They're all going to have either the same or very similar calcium amounts, and same thing with vitamin D. The difference is the fat and the calories. So an easy way to cut down on those fats and calories is to switch from something like whole or 2% milk to a skim milk or a low-fat milk. That's a great question. Anything else? Well, if there are no more questions, again, everybody, thank you so much for having me back. I love being here with you all. I was so excited when I got the message asking me to come back. I'm like, okay, let's get a presentation together. If you do have more questions or you're interested in any of the other classes I teach, feel free to reach out to me. I think my contact information may have been shared out. If not, I will make sure that you all get that information. So thank you so much, everybody. Have a great rest of your night and a fantastic rest of your week.
Allie, thank you so much for an engaging, amazing presentation about one of the things I love the most, food. And in fact, let me just thank Pastor McKenzie for opening with just a wonderful framework for what we were going to be talking about tonight and tomorrow. Thank you, Jaleesa Atkins, Mr. Arturo Puckerin, Jamie Lewis, Tori Jones, Ramisa Cage, and Ali Rogers. And of course, our sister Marquetta Frost, Danon Reed, and Christina Crawford, who made this night amazing. We really appreciate what everybody has done to just put together a wonderful first night. And we are really looking forward to having you back tomorrow when we have our second night of this really informative set of discussions. Please bring your questions, please bring your interest, and please bring yourselves tomorrow night. Thank you.